develop your eyes. Now, and there is a notch here. And then maybe something, this distance is also slightly decreased. And this is what this film was about. Inferior rib notching and things like that. When I have given you a hint, look at the ribs, then you should have picked it up. And there is nothing to do with resolution or anything as far as this finding is concerned. Now, with that, if you would have picked it up, I would have shown you this axial. And this axial is a CT scan in acute abdomen. Over to you. Just consider
and CT axial sections in the portal venous face of 65-year-old male patient having history of, I think, acute abdominal pain, you said. I am scrolling from the top. I can appreciate that there are bilateral pleural effusions more on right side and also in the liver, and there are a few low density lesions especially in the left lobe of the liver. I am going down. I can appreciate that there is a mild thickening of the stomach in the region of the gastroesophageal junction. In the rest of and there is the gallbladder shows a mild thickening with a small amount of pericholecystic fluid. I'm trying to see. I think there is some discontinuity, and the stomach shows stomach is distended, show their fluid levels. So confining to the upper abdomen. In summary, in this there is also a mild thickening of the Girota's fascia and lateral conal fascia. So in this patient, there is a right-sided bilateral pleural effusion more on right side, and thickening of the gastroesophageal junction, also diffuse thickening of their stomach. And besides, there are signs of acute cholecystitis with acute inflammation.
disregard this finding. That's nothing. Anything else?
So of the gallbladder, you are saying?
Yeah, disregard the gallbladder findings.
Okay, there was a thickening of the also the first part of the duodenum, I think, right over here in the region. So this could be. I am looking for any fluid surrounding this in the region of the gastric pylorus.
Madam, can I stop you there? You don't use the mouse to point to the examiner unnecessary. When you are scrolling, you have to speak what you are seeing. You cannot say that I can see thickening here. Tell him that there is thickening of first part or whatever, things like that. Over to you.
Okay. So I am looking at the first part of the duodenum. There is a slight thickening of the first part of the duodenum, and I can see that there is fluid surrounding it, and also some loci foci of the gas in the vicinity. In my routine practice, I would like to see this on the lung window to confirm this air outside the lumen. So this could be a case of perforation at the site of first part of the duodenum.
I've given you the lung window.
Okay, I can see a spot of the air in the vicinity of the previously mentioned
Where is
region of
it?
the bowel, that is the first part of the duodenum.
Where is it?
So
Point out to me. Where is it?
right over here,
Where you
some
are
dots.
pointing?
Sorry,
Where you are pointing? Where are you pointing?
so right over here
Where?
in the vicinity.
This is in the lumen you are pointing out. This is in the lumen.
Yeah, right over here. This one. Can you
Okay,
see
thank
my?
you. Thank you. So this is a case of localized perforation of the junction of D1 and D2 segment. The key thing is that uh, i- if you see here, this is the D2 where I am pointing out. This is the D2, and this thing is sitting outside. So the description has to be that there is a focus of gas which is extraluminal abutting the D1 segment, D2 segment, and then there is surrounding fat stranding. And it is a simple case. So there is localized perforation. Okay, fine. Thank you. Uh,
Thank you.
Next candidate, is this the candidate four? Four. Sorry, five, isn't it? Candidate five.
Yes, sir.
Okay, candidate five. This patient is a 43-year-old, came with fever and confusion. So we have got an MR. Over to you.
Sir, I request the control.
Yes, I've given you the control. Over to you.
Yes, sir. Sir, this is a 41-year old male. I am provided with the MRI brain FLAIR images. I am going from down to upward. First, I will scroll through the image, then I will talk about the abnormality. At the level of corona radiata and right centrum semiovale, I can appreciate diffuse altered signals which are hyper intense on the FLAIR images, which can be represent vasogenic edema, but I can't definitely see any associated lesion along this, and I can't appreciate any abnormality in the rest of the images. Rest of the structures, including midbrain, thalami, brainstem, are normal. Ventricles are normal in size. I would like to see the pre and post contrast images to see any enhancing lesion in adjacent to these at the area of centrum semiovale and corona radiata on right side.
Okay, thank you. Give the mouse, leave the mouse. I'll show you.
Yes, yes, sir.
So pre-contrast is irrelevant. I've given you the post-contrast.
Okay, sir. Thank you. There is pachymeningeal thickening seen along the right side along the front of frontal lobes.
What do you mean pachymeningeal?
So sorry, leptomeningeal, because it is extending along the sulci.
Mm-hmm.
There is a patchy enhancement areas seen, which I appreciate on the flare abnormal, which I appreciate on the flare, which are abnormal. These areas shows patchy enhancement like this.
So what is your conclusion?
So it can be a post-infective process, which is causing cerebritis and associated leptomeningeal thickening.
What kind of infective process?
Can be meningitis
What kind of
or
meningitis?
can be bacterial. The other
Mm-hmm.
possibility is granulomatous disease process, which can be sarcoidosis or tuberculosis, but these are not in the favor because I can't see anything enhancing tuberculosis in this case.
Are rin-enhancing tuberculomas must for
No,
TB?
sir. No, no.
Then
It can be meningitis, maybe tuberculosis. I would
what
advise the rest of the
you
clinical
you have
lab correlation. And
you have talked about sarcoidosis. What else can it be?
so, what are the involvements of sarcoidosis? Are
I am asking you differential. You have said other than
yes, sir.
meningitis, you have said sarcoidosis. I'm asking you what else can be in your differential.
So, leptomeningeal carcinomatosis, but it shows diffuse nodular thickened enhancement and like masses. And the history should be known in that case.
What will you advise next?
So, I would advise the clinical lab correlation and CSF analysis of the patient to confirm my findings.
Okay, thank you. These are old cases: neurogenic tumor, schwannoma, inferior rib notching. Case 8 was duodenal perforation. It was peptic ulcer disease. This is TB meningitis. So just a quick recap. Dura and arachnoid together are known as pachymeninges, and arachnoid and pia is known as leptomeninges. And please remember that the vessels are in the subarachnoid space. So they are PS inside and arachnoid will be outside. So when you see a vessel, that will be in subarachnoid space. This is your differential diagnosis, which is extremely important for the exam, that uh, what kind of things can cause pachymeningeal enhancement. Infections are there, and there are so many others which it is one of the most important differentials. Uh, and then leptomeninges. Always remember that carcinomatosis versus granulomatous versus meningitis, all of these things, and sarcoidosis should be always kept in the differential because it is known as the greatest, what we call mimicker in neuroradiology. There is another differential in your book, which is sulcal uh, player hyperintensities, and this is what I showed you, and the candidate picked it up very well, so well done. Once you see sulcal high signal, you asked for post contrast. Please remember that one of the pitfall is that subarachnoid hemorrhage, which is no more visible on CT scan, can also show as high signal on FLAIR. So you give contrast, it will not enhance. There is another differential diagnosis, which is close to what we are seeing, is ependymal enhancement, which is common sense. If there is inflammation or a tumor, etc., within a ventricle, you will see enhancement. Now, TB. Now, this is a case of TB. Now, first of all, you must have clear-cut concepts about these words. CNS TB can be just tuberculous meningitis. So the patient might have only enhancement of the meninges. They can be tuberculomas. Tuberculomas classically are like this. They are nodular, but sometimes tuberculoma will develop abscesses and necrosis. So please remember that these are two different things. Tuberculomas usually enhance, but when there is necrosis, then they become abscesses. In this particular case, the tuberculomas are showing enhancement. One of the key thing is one of that key thing is that on a T2 weighted sequence, at times tuberculomas are low signal, and similarly, fungal tuberculomas can also be, not tuberculomas, but fungal nodules can also be low signal on T2. Here you can see that the subarachnoid space is enhancing. I'll come back to this finding. Now, there are a few learning points in this case, which is from my collection, in which this was a young patient with TB meningitis. On a flare sequence, we can see a bit of hydrocephalus. And why is there hydrocephalus? When we give contrast, you can see enhancement in front of the midbrain. If you look at the sagittal, it tells you what is happening. Look carefully. This is the pons. Superior to the pons is the suprasellar cistern, and here is the interpeduncular cistern. On a cis sagittal sequence, it is filled up with granulomatous matter. So whole of the subarachnoid space is blocked, and when we give contrast, it enhances. So uh, this is a close-up of the finding which I was showing you. So develop your eyes on this. So whole of the subarachnoid space is replaced. And this is why in the sixth edition of Chapman, there was a differential which is enhancement of ependymal and subarachnoid space. The word was written there, subarachnoid space. And this is to explain it as if there is a canal here, and because there is fuel inside, whole of it is on fire. So this can happen with TB and things like that. This is a CT scan where you can see this enhancement in the sylvian fissure. And of course, there is leptomeningeal enhancement with that. This is the MR of the same patient where we can see that on a flare there is high signal and then enhancement here. And another case of basal meningitis, we can see, look at this rim around so this is pia mater, right? And this time the subarachnoid space is not on fire, but there is a lot of enhancement surrounding it. So you can see the spectrum of findings which we can see on TB. So this is an interesting case, which is a trick case because in this case we have given contrast, and if you do not pick it up that we have given contrast, at times people confuse it with subarachnoid hemorrhage. So if you see the patient has got developing hydrocephalus, key thing is look at the basilar artery, and the basilar artery, this is the basilar artery, and then you can see that there is enhancement. And if you look carefully, then if you go all the way to the top, look at these sulci, and you can see that the sulci are effaced. So even on a CT, there is a bit of a difference because leptomeningeal enhancement, when it is bilateral symmetrical, there is a bit of subjectivity on a CT scan. So this is a case of leptomeningeal enhancement. This case is a good concept case where this was bacterial meningitis. You will not find this finding in each and every case. So don't think that you will see it every time. But if you see here, the pia mater, which is adherent to the brain, is enhancing. Please remember in pediatric radiology, there is a concept of epidural effusions. Subdural effusion. So there can be fluid in the subdural space because of infections, etc. And in this particular case, it is not subdural space because it is subarachnoid space because the vessels are inside. So there is no subdural effusion, but this might be an incidental finding of prominent subarachnoid spaces, which can happen and should not be confused with atrophy. So this is leptomeningeal carcinomatosis in another case where on sulci are high signal on flare sequence and then they enhance on post-contrast sequence. Sarcoidosis, the greatest mimicker. In this particular case, you can see a parenchymal granuloma. You can see this pachymeningeal enhancement. You can see infundibular enhancement. So always consider that also in the differential. And this is uh, subarachnoid hemorrhage, which is slightly old subarachnoid hemorrhage, 6 days old, which was not visible on this CT. These are done on the same day, but on flare sequence, we can see some high signal. It should be actually black like this. And if you don't know that there is subarachnoid, you give contrast, it will not enhance, and you've got your diagnosis. So this is Sulcal. Okay, well done, candidate. This was candidate 5. So now is your second last case. Again, there is a problem with my software. It is not projecting. Okay, now we are there. So, candidate, over to you. This patient came to the A&E with pain abdomen. So, 45 years old female. Over to you.
This is the X-ray abdomen frontal projection of a female patient, in which I can appreciate a small foci of calcification in the bilateral lumbar regions, which can be in the kidneys or pancreas. Next, I can find the haze, which is displacing the transverse colon inferiorly. And there is bowel gas pattern is non-specific. There is no evidence of free air or pneumoperitoneum. Visualized bones are normal, and rest of the structures are normal. So in conclusion, there are a lot of calcifications seen in the region of the bilateral lumbar regions, which could be due to the chronic pancreatitis, or because they seems in continuity. So less likely possibility they are in the renal area. I would like to see the post-contrast CT of the patient if available. Okay, this is, sir, can I request control again?
Yeah.
Sorry, sir, it's.
Okay, I'm scrolling for you. So I'm going up. Now I'm going.
This is this post-contrast CT abdomen photovenous phase, in which I can appreciate the liver is normal. There are innumerable calcifications seen in the distal pancreatic body and the tail. However, the pancreatic head appears normal. These calcifications are also seen in the region of head and body. Pancreatic duct is also prominent. There is no definite mass lesion is appreciated within the visualized pancreas. There is no associated fluid collection or peripancreatic fat standing. There is no evidence of intrahepatic biliary dilatation. There is no evidence of any congenital abnormality like annular pancreas. Visualized kidneys, adrenals are normal. No evidence of free air in the visualized abdomen. I would like to see the uh, lung window to see any free air and to bone window any bony abnormalities.
So both were unremarkable. What is your conclusion?
So in conclusion, it's a case of chronic pancreatitis.
So why is the patient having pain?
Sir, I can't see any signs of acute pancreatitis in this
Okay
case.
then. Thank you. Thank you.
Okay, sir. Thank you.
Okay, this is a case of acute over chronic pancreatitis. So once you have picked up calcification, which was well picked up, nobody is stopping you to ask for this. So this is a feedback for now the second candidate that ask for a magnified view. Say that in my clinical practice, and this is what you should do, because in your description you said that unlikely to be renal because of, the point is that it cannot be renal. The point is it is going over the what we call the spine, and you can be absolutely confident. Once it crosses the spine, so ask for this. So this was the main thing. Second thing is that this, I think you use the word displaced. You should not have used the word displaced because this is just normal variant. It is a redundant transverse colon, which can go all the way down into the pelvis. Now, as far as acute over chronic, now you had picked up the finding. Now, uh, the point you had confirmed, should I say, that there is calcification here. Now, if you look carefully, your eyes should be looking at signs of pain. Now, what is happening here? And I would have asked you anatomy question, lateral conal fascia and what is what and things like that. And there is fat stranding. Look at this fat stranding. And that is why I was showing this case, because the findings were there and you had to pick them up. So, and there is fat stranding here. So there is acute over chronic pancreatitis. Another feedback is that you said that there is no pneumoperitoneum, and then you asked for a lung window. So it should have been vice versa. You will say that I want to see a lung window to rule out pneumoperitoneum. So that's fine, but there was a bit of fine touch. Okay, thank you.
Thank you, sir.
Last case, sorry, last candidate 6, are you with us?
Yes, good evening, sir.
Okay, so this is a 41-year-old. He had a midline swelling in the neck. Patient is very claustrophobic, declined an MR, so ended up doing a CT scan.
Okay, so this is an axial CT scan uh, of the neck. I would like to scroll first and then give my impression. Okay, sir. Sorry, the scrolling.
Madam, the patient has got a midline neck problem, swelling. So concentrate on that area, disregard everything else.
Midline neck, okay. Okay, I can see that the thyroid is seen enlarged. The right loop of the thyroid is seen enlarged. And I can't appreciate the left loop of the thyroid. Sorry, doctor is not scrolling smooth with me. Yeah. Here in this area, I can see there is hypodensity.
Madam, midline neck. Midline neck is, clinically speaking, what
Okay.
is that? I am not at all interested in anything else. Please
Oh,
concentrate on midnight. There was a swelling, right? There was
yes.
a lump, a nodule, whatever.
Here I can see there is a midline hyperdense area seen and within the anterior to the isthmus of the thyroid. So I'm suspecting this might be is not cystic. It's appear hyperdense. So I'm suspecting this might be a nodule seen within the thyroid isthmus with enlargement of the right thyroid loop.
What do you mean thyroid isthmus?
Thyroid isthmus?
What do you mean thyroid isthmus?
No, the isthmus of the thyroid.
What is that?
The part between the two loops of the thyroid, the isthmus.
Oh, so you're talking about that. So is there a connection with the thyroid, this nodule?
Let me check it again. No, sir. Actually, it's not connected into the thyroid. Yes, it is in front of the trachea. Yes, this is the trachea. So yes, this is a hyperdense rounded, well-defined nodule seen with anterior to the trachea. I'm thinking this might be ranula.
Ranula.
Hmm?
What is a ranula?
This is the nodule seen within the neck.
Okay, madam. Thank you. Thank you. This is what it is. This is ectopic thyroid. So please remember that sometimes the thyroid tissue is ectopic, and you have to remember your embryology to be able to pick this up. This is from your book, Visceral Space Lesion. So there is something thyroglossal duct cyst, but there can also be ectopic thyroid. Key embryology concept is that actually uh, there is a foramen cecum in the base of the tongue from where the thyroid actually in a fetus, it starts growing from there. There is a duct which is known as thyroglossal duct. This passes through the developing hyoid bone. and ultimately it goes to the pyramidal lobe of the thyroid and then goes right and left. So this is how it descends down. Sometimes this thyroglossal duct remains patent when the baby is born, and even in adults, it can present with a cystic lesion. So, key thing is it a cystic lesion? And please remember, it will always be midline. Superior to the hyoid bone, it will be always midline. Inferior to the hyoid bone, it can be slightly para midline within the strap muscles. So it will be very anterior. Anatomy is key, embryology is the key. So thyroglossal duct cyst is an exam case, and the eye see what the mind knows. And it can be infected, for example, here, and a location tells you what it is. This is known as visceral space. Visceral space is a cylindrical space contained in middle layer of etc. Contains thyroid, parathyroid, level 6 lymph nodes, larynx, cervical trachea, and esophagus. So these are the things which you can see. So this is the pyramidal lobe. This is the pyramidal lobe. So this is a case of thyroglossal duct cyst. We can see hyoid bone here, and we can see this cystic lesion. Cystic lesion. It is slightly off center, and it is within the strap muscle, and this is the thyroid. On the other hand, our case was this. This is ectopic thyroid. This is a case from ACR, which non-enhanced CT, and you can see, this is where the foramen and cecum is. You can see this high density. And this is the key thing is that even because please remember, thyroid has got iodine, and even on a non-enhanced CT, it is slightly hyperdense. So you can see this nodule. When you see this nodule, always look at the thyroid bed. And the key thing to remember is that if you make a mistake and they remove it, the patient will become hypothyroid. So at times, this ectopic thyroid might be the only viable thyroid tissue the patient has. Just like in this case, there is no normal thyroid. So this is the location of ectopic thyroid, lingual thyroid. This is a case from our hospital where the patient presented with midline neck swelling, and there was a solid mass on an ultrasound. The report was that we should do an MR and we should consider biopsy, MDT discussion, blah blah. So on MR, this is the MR. In this case, the thyroid is normally seen also, and there is a bit of hypertrophy, and this is that tissue, just like the case which I showed you, it is going superior. The key point is that on all sequences, the signal intensity is equal to the parenchyma, and then you know your embryology, and then you can be very confident. So this, our case actually was ectopic thyroid, and I will quickly show it to you, and then we will go to the last case of the day. So here you are. Now, if you see here, this is this is the midline, this is the base of the tongue, and then this is the hyoid bone. We are going inferiorly, and here comes this nodule. Here comes, and look, it is very well defined. It is midline. It enhances equal to the thyroid. So in this particular case, the right lobe is visible, the left is not seen, but there is a bit of ectopic thyroid tissue here. Okay, last case of the day. So, madam,
Yes,
this
doctor.
is a 72-year-old male, pain epigastrium off and on since 2 years. The patient came to A&E. The surgeon wanted us to rule out mesenteric ischemia particularly. So we did a CT scan. So I am going to share it once again. Yeah, here you are. You can see it.
Yes, just I.
So you can ask for the mouse. This is last case of the day.
Okay, thank you. Request remote control. Sorry, doctor, I can't scroll. Could you please scroll it to me? No, no, I'm scrolling now. Thank you.
Just concentrate on the upper abdomen and forget about everything else.
Okay, this is axial CT abdomen with contrast, with arterial contrast for a patient presented with upper abdominal pain. Okay. The patient is presenting with epigastric pain, so I would like to check the epigastric area. I can see that the pancreas appear normal with no surrounding fat stranding and no dilatation of the pancreatic duct. The gallbladder also appear normal. CBD appear normal for me. I can see that the stomach appear it's not filled, but there is circumferential gastric thickening, which I would like to follow. Yeah, okay, it's the esophagus going down. Yeah, it is seen mainly in the fundus and the body of the stomach.
Right, that is one finding. Anything else?
I will scroll down to the duodenum. Also, there's also duodenal thickening, pyloric, and no, this is the pylorus, sorry, and this is the duodenum. Yeah, there's a enhancing lesion seen here within the duodenum. I would like.
Where is the enhancing lesion in the duodenum?
Here, this one. Can you see my pointer, doctor?
Is it in the duodenum?
It's extraluminal, but adjacent to the. I think this.
Adjacent to the duodenum. Okay.
Yeah. I will check the going down.
That's fine. So you have picked up two findings. What is your conclusion?
Okay, for the in my routine practice, I would like to check them in the coronal view as well. For the duodenal lesion appear extraluminal.
Here you are.
Okay, thank you. Yeah, there is the circumferential wall thickening of the gastric mucosa. I can see it, and this is suspicious for a malignant process. And I would like to scroll down to see the duodenal lesion. Yes, this lesion is seen enhancing medial to the second part of the duodenum. It is enhancing with central hypodense area.
So conclusion, madam. Conclusion.
I'm suspecting that this is a malignant gastric malignant process. I would like to And for the duodenum, I'm suspecting that this might be leiomyoma or part of GEST.
Will it enhance like this?
Not really. For leiomyoma, it will not enhance like this, but maybe for the GEST.
Final, give me the final diagnosis. We are out of time.
Okay. GEST. I would like to. This is might
Yes.
be part of the
Okay.
GEST.
Thank you, madam. Thank you. You picked up the findings very well, but the eye see what the mind knows, right?
Yeah.
So the point is that uh, I have this is a classical 2B case. This is a gastrinoma, Zollinger-Ellison syndrome. Let me tell you the background of this. Now, pancreatic tumors can be solid and can be cystic. I think 2 or 3 sessions ago, we did cover the cystic lesions. Now, solid lesions, the most common is the pancreatic carcinoma, and then there is pancreatic neuroendocrine tumors. Neuroendocrine tumors can be benign, they can be malignant. Now, this is from your book, Solid Pancreatic Lesions. Look at this heading. And this heading is a take home for you. Hypovascular, these are the lesions which are not, they don't enhance. Ductal adenocarcinoma, the classical pancreatic carcinoma, is low density. On the other hand, uh, hypervascular. And there is a, long list of neuroendocrine tumors. These are hypervascular. Now, one of them is gastrinoma, presents with multiple peptic ulcers, Zollinger-Ellison syndrome. Look for diffuse gastric fold thickening. The eye see what the mind knows. And this is what the exam is about, that 2 plus 2 makes 4, a unifying diagnosis. Please remember that majority are malignant, typically located in the gastrinoma triangle. So your eyes should be trained for. You picked up the finding beautifully, so well done for that. But you could not make the connection between the two, which includes the head. And I'll show you a diagram to show this. This is what it is. When you see the neuroendocrine tumors of the pancreas, they can be hyperfunctioning and non-functioning. Now, look at the names: insulinoma, gastrinoma, glucanoma, VIPoma, somatostatinoma, ACTHoma, GRFoma, parathyroidoma, carcinoid. Now, look at the malignancy rate. The minimum is insulinoma. 10% are only malignant. Gastrinoma, most 60 to 65%. Some of them are close to 100%. Look at this, 100% malignant. But these two are most important for your exam, insulinoma and gastrinoma. Now, what kind of cases can come in the exam? If you know the basics, you can see what kind of cases can come. Gastrinomas are multiple in 60%. So once you pick up one, keep looking for second or third or fourth. They can be large. They are in the gastrinoma triangle. Develop your eyes to look at the gastrinoma triangle. So they can be extra pancreatic. How much? 15% of them. Key finding: they can be with 20 to 25% with MEN1 syndrome. So you should know the definition of MEN1. And they might give you a long case, or they might give you what we call a viva case. Now, this is the definition of MEN1. Pancreatic neuroendocrine tumor, right, is one of them. And look at this, parathyroid adenoma. Suppose they show you a hand film with a hyperparathyroidism, and with that a net, then you should understand that the final diagnosis is MEN1. So these things are extremely important to make 2 plus 2. I can even give you a meningioma with it, and you can say this patient might have MEN1, because then my questions will be clinical. What will you do? And you have to rule out all of these tumors. So for all of these tumors, I do not have time right now, but they will ask you, what will you do? And you have to think deeply that what kind of investigations are you going to advise? Ultrasound for something, MR for something, nuclear for something, etc., etc. So this is a case of insulinoma. If you look carefully, this is the SMV, and there is a hyperdense enhancing lesion at the head of pancreas, which was hypo on ultrasound scan. Please remember another thing, that neuroendocrine tumors can cause, other than hypervascular, they have got calcification. So usually pancreatic adenocarcinoma, unless it is over a background of chronic pancreatitis, might not have calcification. So this one is enhancing. Look at this calcification with enhancement on a plain film. So this is the viva starts on a plain film, and you can see this nodule. And what can it be? And you can say it can be in the region of pancreas, it can be adrenal, it can be whatever, mesenteric. Then they will show you a CT, and it might be an enhancing neuroendocrine tumor. This picture should be etched in your brain like anything. And this is an exam diagram from radiographics. This is gastrinoma triangle. So they can be within the pancreas, they can be in the groove, they can be outside the duodenum. Our case was sitting here, it was outside. It was infralateral to the duodenum, remember that. And all the way up here till the cystic duct. This is what we call, they can be inside the groove, they can be outside the C of the duodenum. So this is the key. And then 2 plus 2 makes 4. Look at the rugi. So this was rugal thickening, which I showed you. And this is a subjective type of a phenomena where you develop your eyes on rugal thickening. So this is another case where there is an enhancing lesion here, which is partly projecting into the lumen of the duodenum with some rugal thickening. And this is Zollinger-Ellison syndrome. There is another differential diagnosis in your book, gastric fold thickening. Please remember, on a CT scan, you have to, it can be tricky finding, but in classical cases, you will pick it up. Increased prominence of gastric folds versus, thickening of all of the wall. Zollinger-Ellison syndrome due to gastrinoma causing excess acid secretion resulting in multiple or recurrent gastric and duodenal ulcers both in D1, D2, etc. So this is because of response to excess acids. And with that, I will show you a case from my old collection. Look at this one. This is a classical exam case. This case presented 60 years old, clinical episodes of severe pain, abdomen, mesenteric ischemia. So we did a axial, non-contrast, and you can see this rugal thickening. I'll show you post-contrast. This is, and there were a lot of what we call calcification, etc., etc. Now, so this is a beautiful case, a classical exam case. And then we have got axial arterial. Please remember, we did a CTA actually in this case because of the clinical, they had asked for that. On this, you can see this enhancing. Now, this is metastasis. This should be taken worrying for a metastasis. Carcinoid metastasis, remember, that also enhances on, and look, this is rugal thickening. I'll come back to this on post-contrast. Now, this is SMA, and sorry, the celiac artery, the SMA. And now the pancreas is coming into our, and here you are. You can see this enhancing lesion here. You can see this enhancing lesion. So this is coronal. Look at this. This gives you rugal thickening on a CT scan. Look here, same thing. This is that enhancing lesion. And on a sagittal, here you are. You can see it very well, the lesion which I was showing you. On a portal venous phase, look at this. This is how rugal thickening looks like cerebriform form, like a, cortex of the brain, right? Brain gyri, that kind of appearance. And then you can see the washout on that metastasis. So this is a metastasis. And so this is Zollinger-Ellison syndrome. And this is the pancreas, and the lesion is sitting here in between, the pancreas and the duodenum. So with that, let's go through your case. So your case, you picked up the finding very well, so very good about that. First of all, I just want to show you the Rugi. If you ask yourself, you have to develop your eyes on these things, because you can see how it gives you that cerebriform type of appearance. It's not classical thick wall, which will be more diffusely enhancing. So this is rugal thickening, but you picked up that finding very well. Now, if I go back to the axial and see it here, now this is the head of the pancreas. This is the D2. This is the head of the pancreas. This is the uncinate. So I'm coming towards, this is D2. And now comes the lesion. This is D2 and D3. Now here is the D3. You see this D3 goes there. So this lesion is sitting outside the duodenum, lateral to it and slightly inferior to it. Still, it is in the gastrinoma triangle, which I showed you. So this is the C of the duodenum, and the lesion is sitting outside inferior and slightly lateral. So this is gastrinoma with rugal thickening. Okay, well done. You picked up the finding very well. You could not just, join them together. So well
Okay.
done.
Thank you, doctor. Thank you.
Okay, now, the point is that next session will be slightly different. What I'll do is I'll select cases from what we call temporal bone, base of skull, and maybe CNS. I'll see. But my main aim is to consolidate your temporal bone anatomy, and there is no better way than to see more on core cases of the same thing. So next session is going to be different. It's not going to be classical potpourri. It's going to be temporal bone, base of skull, or CNS, that kind of structure. Okay, then, thank you very much. Next session is next Thursday.